Good afternoon and welcome. Sorry for keeping you here on a Sunday. After this session, we'll give you all time off. You can take tomorrow off when you go back to your institutions. My name is Deus Bazira. I'm a director of Georgetown Global Health Institute and also direct the Center for Global Health Practice and Impact. I'm also an associate professor of medicine at Georgetown University Medical Center. So today we're going to have a panel of distinguished speakers who I will introduce shortly, but before I get to that, I just want to do a quick intro. Yesterday and the day before that, we spent time in different sessions talking about debating definitions of global health, discussing the future of global health, trying to reimagine it in the 21st century. And in one of the sessions, we were debating whether we should broaden the scope of global health or narrow it. And I believe all those discussions have led us to today. Why? I think there is a recognition within this room and outside that we should have achieved more impact in global health. Despite all the challenges that we face, resource constraints, I think we could have achieved more. We should have achieved more. And it doesn't matter how you view global health, whether you view it from an expansive perspective or from a narrow lens. So hopefully through this discussion today, we'll figure out ways we can amplify the impact in global health practice. I'm going to start off with two quotations, one from Louis Pasteur, who is very well known to all of us here today. He said a long time ago, "To him who devotes his life to science, nothing can give more happiness than increasing the number of discoveries. But his cup of joy is full when the results of his studies immediately find practical applications." I think, it's a long time ago, but he should have said, he or her, he should have been more equitable in the way he viewed the world. But his point is taken. And then Agri and Reshna say that the ability of science to deliver on its promise of practical and timely solutions to the world's problems does not depend solely on research accomplishments, but also on the receptivity of society to the implications of scientific discoveries. Why are we here in this session today? 8 million children die from pneumonia, measles, malaria, and other preventable diseases every year. Pneumonia and meningitis alone result in 8 million cases annually and about 307,000 preventable deaths every year due to Haemophilus influenza type B, despite availability of H1B vaccine. There are some studies that show it takes sometimes between 17 and 20 years to get clinical innovations into practice. And fewer than 50% of these innovations ever make it into general usage. In fact, when you take all this collectively, about 80% of medical research investments, some studies say, do not make a public health impact. Why? It can't all be attributed to advances in technology, triability, and feasibility of these innovations. So there must be some other reasons. A specific example that some of you have heard me cite, citrus to treat scurvy was first observed in the British Navy in 1601. First randomized control trials conducted in 1747, and eventually it was adopted for routine use to prevent scurvy in 1795. It took 194 years later to routinize the use of this intervention. I must say the record today is not different. However, the uptake of some of these clinical innovations differs depending on what it is you're talking about. Smallpox vaccine, penicillins, and insulin took longer to adopt, but the good news, antiretroviral drugs to treat HIV/AIDS were adopted, more rapidly. So there is a record that shows you can adopt these innovations rapidly for routine use. So I'll conclude by saying that contextual factors, not treatment effectiveness, play a dominating role in whether and how quickly a clinical care process innovation will become widely used. And to help us today debate and discuss these issues, we have 3 presenters here. I'm going to introduce all of them at once, and then I'll be calling on them one by one to come and make their case about the issue they would like to address. We're talking broadly about implementation science, which includes both implementation research and practice, bringing together implementation science as a discipline. And then after they've each spoken, I will ask 1 or 2 cross-cutting questions for them to address, and then we'll open the discussion to the audience for questions. So we'll start off immediately on my left with a colleague of mine I used to work with for a long time at University of Maryland in Baltimore, Dr. Nadia Sam Agudu. Dr. Nadia Sam Agudu is a pediatric infectious disease specialist and an associate professor of pediatrics at the University of Maryland School of Medicine. She also serves as a senior technical advisor for pediatric and adolescent HIV at the Institute of Human Virology in Nigeria. Her research focuses on the application of implementation science in the prevention and treatment of HIV and other major infectious diseases among children and adolescents in the African countries. She's the lead and PI for the Central and West Africa Implementation Science Alliance. She's also a member of the Nigeria Implementation Science Alliance and Fogarty's Adolescent HIV Implementation Science Alliance. She's also a PI for a D43 training grant named Expand to train postdoctoral Nigeria researchers in implementation science applications in HIV research. Welcome, Nadia. And then she'll be followed by Dr. Jen Cates. Dr. Jen Cates serves as a Senior Vice President and Director of Global Health and HIV Policy at Kaiser Family Foundation here in Washington, D.C., where she oversees policy analysis and research focused on the U.S. government's role in global health and on the global and domestic HIV epidemics. She also helped lead Kaiser Family Foundation's work on the COVID-19 pandemic. And finally, someone whose face you've seen this whole week, Dr. Peter Kelmax, an expert in global health and infectious disease research, policy, and programs. He serves as the acting director of the John E. Fogarty International Center, and is also the acting associate director for international research at the U.S. National Institutes of Health. He's a preeminent center for global health and capacity capacity strengthening that refers to the Fogarty Center, where he currently acts as the director. He previously served as the deputy director of Fogarty and as the country director in Zimbabwe and in Botswana for the U.S. Centers for Disease Control and Prevention, and as chief of CDC's Sexual Transmission Research Section in Thailand. Other CDC leadership positions included senior advisor to the Director of Health Reform and chief of epidemiology branch, both in the division of HIV/AIDS prevention. Dr. Kelmax served in leadership roles in CDC's Ebola response efforts in the Democratic Republic of Congo, Sierra Leone, and Guinea. Peter served for more than 20 years in the U.S. Public Health Service, rising to the rank of Rear Admiral. You're all welcome, and we look forward to hearing from you. Nadia. Over to you.
So good afternoon, everybody. And I thought it would be good for us to start talking about some core definitions in implementation science. If we are going to be discussing implementation science and sustainability and building capacity, we need to all understand what it is that we are talking about. So with apologies to those who have heard these terms and the definitions a million times over, I'm still going to go over it so that we are all starting on the same page when we have this discussion today. All right, and actually Deus has already given us the background of why implementation science is needed, and so I'm not going to go through this slide, but I'll give an example from my own personal life. I have 2 children. My second child was born in 2006, just as US was licensing the rotavirus vaccine. He was actually a little bit too old, even as an infant, to get it. He just missed the window, and this poor young man had rotavirus of such severe consequences that and if I were not a physician and a pediatrician who acted quickly, he probably would have died. And let me just say, I gave him ORS and said, you're not going to the emergency room. You're at a point where I can give you ORS. And I did that. And, you know, he's 17 years old today and give me a lot of trouble at home. But that's another story. So I'm going to skip over that and really go into the definitions that I wanted to talk about today. Given the story of my son just missing, he was born in the US, just missing rotavirus vaccine, the example I want to add on to that is that of Nigeria, where in, say, 2021 or 2022 was when rotavirus finally became available on a wide scale to be scaled up throughout the country for infants to get access to. So you think of my son who was in a position to have gotten rotavirus vaccine, right? He was just a little bit too old. 2006 to about 2021, 2022, when it's finally available for infants and children in Nigeria, you know, that is now, you're talking about what, 15, 16 years. That is way too long to wait for children in other parts of the world to get access to this vaccine and to save lives, because rotavirus is a significant diarrheal illness that takes the lives of children very, very quickly if you don't act fast enough. So I want to start off by defining some of the terms that we'll be using so that we all can ask questions and understand what we're talking about. And starting with implementation science is the development and study of methods to promote the systematic adoption and integration of evidence-based practices, interventions, and policies into routine healthcare and public health settings, and hence, to improve the quality and effectiveness of health services. Note the terms adoption and integration. A lot of times when I'm lecturing on implementation science, we talk about adoption being on the part of the providers or the service deliverers, and uptake being on the part of the patients or receivers of these services. Now we can then talk about implementation research. So I'm going very technical with you all today. We tend to interchange the way we use these terms, but I'm being a bit more technical here so that you get sort of the subtle differences here. Implementation research is a subset of IS and is a systematic application and study of methods, of IS methods in real-world health service delivery contexts. So investigators here examine how interventions can be adapted to specific contexts, how context influences effectiveness, and what implementation strategies to use to maximize quality and effectiveness. Now we have implementation scientists who are theorists, and then we have implementation researchers are the ones who really take these methods and apply them into research. Okay, let's try this again. Yes. So just a schematic to show you the same information and a bit more in a different way. You have intervention research, which is generally how we think about research, right? You're looking at focusing only on efficacy or effectiveness of an intervention. So the question, the broad question you're asking is, does it work? And then you have implementation science, which then takes it further. And the questions we are asking are, what methods and tools do we need to accelerate the use of this evidence? So implementation research asks the question, you know, does this EBI, does this evidence-based intervention work in this context? How can we make the EBI work in this context? So we have a lot of how and in this context being applied in implementation research. And then what strategies make the EBI work best in this context? Then we have implementation practice, which is something that we often don't talk about broadly, where we are now looking at applying the evidence that is coming out of implementation research and asking the broad question, how do we successfully implement the EBI in everyday public health and clinical practice in this context? So everyday being routine. Now we have people who practice these sciences. There are implementation scientists, and then there are implementation researchers. And the people who do implementation practice are really a broad range of people beyond implementation researchers. So the point of me saying this is that clinicians are not excluded from implementation research. Implementers and public health personnel are not excluded here, and patients are not excluded here. So providers of services and even the receivers of services are all actors in this chain of events that we call implementation science or implementation research and practice. So we will be talking about, how that is different from implementation science, how it is different from improvement science. And a lot of what we do, particularly in public health, we do improvement science. And this table sort of gives us a background of what is different about the two. But maybe I'll leave that for now till we get into the discussion, and then we can use this slide as a talking point. So I'll give a real-life example of some of the work that I do. I work at the Institute of Human Virology, Nigeria. As was mentioned, this is our building in Abuja. And you can see from this building, it has 2 towers. And the one tower on the left, and I'm trying to do this, is in the yellow box there is our International Research Center for Excellence. And then the tower on the right is our Center for Public Health Implementation. I have roles in both towers. I do both research and program implementation. So for me, being able to switch from IR to implementation practice is really a very practical thing for me to do, given the hats that I'm wearing. And so you can see here the focus of what we do in implementation science versus implementation research, implementation science or research, and then versus improvement science. So for example, if we are looking at PMTCT, prevention of mother-to-child transmission, if we are looking at retention, we tend to look at it more holistically or more generally when we are applying implementation research in the work that we do, versus, say, among the networks, the facilities in the network of sites that IHV Nigeria supports, we have problems in certain sites that are poorly performing in terms of retention. So you can have a broader way of looking at retention in PMTCT in Nigeria with an implementation research approach, and then another way of trying to correct or reduce issues or gaps at a certain site or sites that have a particular issue with some of the outcomes that we want to look at. So I won't go too much into that right now, but we can come back to it and discuss that when we are discussing more about the questions and answers. So I will stop there, and thank you very much for your time.
Hi, everyone. Good morning, afternoon on a Sunday. It's great to be here. One thing I wanted to add to my bio is that I'm a proud new member of the Fogarty Advisory Board, so that's an important part of work. So yesterday I spoke on a panel that was focused on how to reach policymakers and the public with data and evidence. And so I think this discussion to me is an extension of that. I'm going to bring that perspective, and so for those of you who were there yesterday, apologies if some of this is repetitive, but as we learned yesterday, repeat, and keep it simple. But when I think about adoption and integration of the evidence to change behavior, I know from a public health perspective, we often are thinking about the individual or community that we want to adopt the intervention. I think about the policymakers and the program managers as the sort of target of the intervention in a sense. So how do we get them to change what they do, their behavior, and based on their constraints and their context, so that we can have better adoption? Because the individual is only going to be able to do so much if, as has already been noted, it's going to take 15 years for things to roll out. So that's going to be my focus. First, I'll provide a short overview of my organization, KFF, since our raison d'etre is to focus on this critical juncture between data generation and analysis and translation and dissemination of that data to key audiences. So we're a nonprofit organization focused on health policy analysis and research. Our hallmark is that we focus on how that policy affects people. We conduct our own research. We do primary data collection and analysis. We do secondary data analysis. We look at both qualitative and quantitative data. And in addition, we have a group of my colleagues who do polling. And we also have a journalism component, because as those of you who work in policy know, policymakers pay attention to the news media. And we do also have some specialized public health information campaigns, but what I'll be focusing on is, my perspective is on the policy analysis research. So if I had to sum up our organization, besides the focus on how policy affects people, I would say we're an information organization. Our product is information. We communicate that information about health policy to a variety of audiences. We don't advocate, we don't take positions, and we don't make recommendations. And that always shocks people, but I'm happy to explain more. But really, the reason for that is that we are striving to be an independent and trusted source of information to inform health policy. And that's somewhat unique to our organization, but it's part of what we see as a role that needs to be played by some actors out there, even in the environment that we're in, where there is so much noise and so much disinformation and challenge to information. It still needs to be there. My area of focus within that broad scope is on analyzing U.S. global health policy. So that means I look at the programs, the structure, the funding, the issues, and of course the politics. Most of what I do is try to take complex information about what we know works or doesn't work and translate that for policymakers. These data and the evidence that I use are varied. They can range from data generated by some of you through like gold standard randomized controlled trials to multivariate analysis of complicated data sets, to data on program impacts, to assessment of where the government is spending money, to case studies, to stories from people. But as noted already, we struggle to get this evidence into policy. And why is that when we have such great information? It shouldn't be so difficult. So some of the things I talked about yesterday, and I'll add to it, I'm going to discuss sort of the barriers and facilitators that get in the way. And some of this I mentioned, as I said yesterday, but when I think about reaching policymakers, there's a whole set of things that have to, align. The stars have to align in a certain way to reach that kind of audience. You have to have the right audience. So are you speaking to somebody that actually can do something with the information you're giving them? Is it the right time? Are you providing understandable and accessible information to them? Is it the right message and the information that they value? It might be great information, they don't value it. Are you the right messenger for it? And do you recognize, and this I think is really critical, their constraints and their context? They have multiple competing priorities and trade-offs all the time. They have very limited time to understand any single issue. They're motivated by votes, by constituents, by elections, by politics, by legislative calendars. And often the issue that they need right now is very current to them. For whatever reason, it's something they need that moment. They're not going to need a study that's coming out in 2 years. They want information today. They might not want it tomorrow. And so that's where they operate. Those are some of the challenges to reaching legislators. I think there's some of the same ones to reaching program managers, and by that I mean even the big P program manager, big M, those who are overseeing PEPFAR or the Global Fund. What are their constraints and the challenges of getting good information? Because we know everyone who works at those places, and we think, well, there's all these great studies that are out, and so they also face constraints. They have limited time to absorb the research. They are running huge, complicated programs and worrying every day about serving people in the field. It's very hard to stop and absorb new information. They are also constrained by the funding they get, the requirements that come with that funding, and the politics around that. It's often hard when you are running something, and I'm sure all of us have had this experience, to let go of things, even if the evidence suggests better use of money or time. And politics always does play a role. So many of these realities they're almost antithetical to how research is conceived of and done, but if they're not recognized, then we will continually run the risk of seeing the evidence be ignored or overlooked. From our perspective, the way we try to contribute to doing this is providing that independent, trusted research as best as we can from the outside. It's not a panacea, but it's an ongoing, evolving process. And sometimes the way I've seen that work, and again, it doesn't always work, there's many ways to influence this complicated environment, but sometimes that push from the outside, that information that's provided at the right time to the right audience in a clear way, it gives the sort of kick that's needed for others to take it to the next place. So I look forward to your questions, and thanks very much.
Good afternoon. Great to be here. Can you load up my slides, please? It's so great to see such a big audience, and they're hungry for this information. Nadia, they're taking pictures of all of your slides, I'm noticing, and I think we're probably being live tweeted also. But it's such a pleasure to be part of this panel. These two women that two women and man, but the two previous speakers I especially know well, and have so much respect for. So I'm going to talk about from the perspective from the NIH and the Fogarty International Center, and more about some of the resources that are available and programs that we have. I reached out to some of my colleagues. I was very pleased to be invited to be part of this, and reached out to some of my colleagues who are real card-carrying implementation scientists at NIH, and they sent me about 200 slides over the last few days. So I was up last night and early this morning, whittling it down to about a dozen of the most important slides and information for you. So next slide, please, or do I do that? Oh, either way. Okay, so first just to say that there's a lot of, my main message is there's a lot of implementation support and activity going on at NIH. At Fogarty, it's part of our strategic plan. It's one of our key goals. We don't have a specific implementation science research training program, but across each of our programs, we welcome and support implementation research and implementation science as part of that. And then just, I'm going to get focusing on giving some examples. I'm not going to be able to describe everything that's happening, but I thought just to give some examples would be helpful to you. So here's one, the Clean Cooking Implementation Science Network, led by Josh Rosenthal. This is looking at the uptake and use of clean cook stoves in low and middle income countries. And just an example of something that's a major health problem, you know, from infant disease, pneumonia, hypertension, asthma, so many different areas. So having a very focused, well-resourced implementation research network was put together, 32 projects in 15 countries, broad number of partners. All those ends are NIH, different NIH institutes, the EPA, USAID, CDC, Clean Cooking Alliance. And put together, you can see that schematic of the different areas of implementation science, epidemiology, economics, medical anthropology, behavior change, and system science. And this is the kind of partnerships and multidisciplinary or transdisciplinary work that's needed for real, implementation science and moving the needle. This other example that Nadia is part of and mentioned, the HIV Implementation Science Alliance, AHISA, really led by Rachel Stirk, who's here and was really is a lead expert, subject matter expert at Fogarty and at NIH for implementation science. And this example is really looking at the great gains that have been made in the 90-90-90, or I guess now we say 95-95-95, in getting people diagnosed and on treatment and with the suppressed viral load, people with HIV infection, how far behind we are with adolescents. And so this group really pulled together, and the key, look, it's researchers, it's program implementers, it's decision makers, it's really having them form groups in the countries, 26 teams in 9 countries, networked and working together, really addressing what the barriers are and putting the policy into practice to improve these outcomes in adolescents. And again, look at the partners there. It includes a number of the NIH agencies and also the World Health Organization, EGPEF, UNICEF, the International AIDS Society. And so that's been a very active and very productive network. And then another, this is the Global Alliance for Chronic Disease. I expect some of you are familiar, but this is an NCD example. Brad Newsom at Fogarty coordinates this, leads this at NIH, but you can see the list of 11 participating NIH Institute centers and offices. So there's, again, broad support and interest for this kind of work across NIH. It really is focused on, in that mission, you can see it's building evidence to inform policies and contribute to the SDG 3.4. There's 15 global members. These are the major funders of research around the world. It's NIH, but it's also the UK MRC. You can see others listed there, both in higher and in middle-income countries. And the way this works is that they will come up with a theme every year, and then generally the funding isn't all pooled, but the different funders will coordinate their calls for applications, and really has created a global network and very productive program. So now turning to just a couple of other of the NIH institutes, from NHLBI, George Mensah, who leads their Citrus Center for Translation Research and Implementation Science, has really put together a nice, just sort of spelling out how we have to go beyond just the intervention, and putting these interventions into practice and policy, both in the clinic and in public health interventions. So just some examples from NHLBI, the Heart, Lung, and Blood Institute. This is about implementing hypertension interventions in low and middle income countries through the GACD network, and really looking at the late stage implementation research to sustainably scale up interventions in LMICs and also small island developing states. And another substantial program ongoing, HLB Simple. This is looking at heart, lung, and blood comorbidities implementation models in people living with HIV. And this has been a global network, and Fogarty's been quite involved with this, and really just, again, another example of another institute that really is quite active in implementation research. And then just a specific program ongoing in supported by NHLBI in Uganda, looking at the treatment cascade. There's been a nice adopting the HIV treatment cascade, looking at the hypertension treatment cascade as a useful model. And now moving to NCI, the National Cancer Institute, also very active. David Chambers is from NCI is a real leader in implementation research. And this here, I'm sorry, the print is small, but it's really highlighting these three research programs, the RO1 for the sort of 5-year substantial support program, the RO3, which is for a shorter time period for research programs, and then the R21 is for research planning. But this is all implementation research and health. This is all foreign entities and foreign components can participate. And what I want to highlight on here is look in that blue box. Look at all of the NIH institutes that are participating in this NIH-wide implementation research program. So it's not just infectious disease. It's not just a couple of institutes. It's some are, frankly, some are much more involved and active than others, but it is quite broad. And just want to call your attention to this annual conference on the science of dissemination and implementation in health. And this does have, as noted there at the bottom, a global implementation science track. So stay tuned for announcements for when that will be, when and where that will be in 2023. And then this is just an example. There's a training institute for dissemination and implementation research in cancer, but the modules there and the information there is relevant to other diseases. So this is a nice open access online training program that if you want to learn more, and this is a great resource. So wrap things up, and I'm looking forward to the discussion and the tough questions that are going to be pitched our way, but just wanted to make this point that there is strong support and diverse support from NIH, and a link there for additional resources, and to urge you to subscribe to our funding newsletter. We have NIH funding information, but also from other funders, USAID, Gates Foundation, others, and every week coming out with funding information that's of interest to global researchers. Thank you.
Thanks to our panelists. You've all been very disciplined when it comes to time, so we will have a lot of questions coming your way. Just to start this off, I'll start with you, Nadia. There is a common criticism that implementation research is not rigorous enough. We know that's not true, because I think the terminologies and the disciplines sort of get mixed up. So how do we dispel this myth? And then where does implementation science, I know you touched a little bit on it during your presentation, where does it fit in the biomedical research pipeline?
Okay, thanks for your question. And my immediate counter question to that is, says who? And what is their criteria for rigor? You know, the very definition of implementation science, it lends to rigor. For me, and the way I've learned it is that there are two very basic principles of what implementation science is. And one is applying the theories, frameworks, and models, you know, to structure and guide the implementation research or practice that's being done. And then two, that the actors in the chain of events that go from designing an intervention to getting it to the audience and to the people who are supposed to be using it or benefiting from it, that involves multiple actors along that chain. So you should be applying theories, models, and frameworks, and you should be involving multiple actors along that chain of events that I mentioned. And in the end, your goal is to make sure that the benefits of the intervention reach the intended population. And so implementation science addresses that. And so in what way then would someone be questioning the rigor? Because we are involving actors along the chain, or because we are using theories, frameworks, and models, which are rigorous. And in fact, among the people I practice with and I interact with on a daily basis, what I often hear is that implementation science is hard. I actually hear that it's very hard, because using the theories, frameworks, and models and applying them, which to me is a very basic principle, can be very difficult. And so, you know, my answer to it says who, because it is rigorous. How we dispel this myth is beyond talking, like I'm talking now. You can talk to your blue in the face, but then there should be actions that validate and value what implementation research is. And you know, Peter said some of that, you know, the funding that's coming from NIH, of course, other funders. And we know in the past there were people who were implementation scientists who were struggling to get funded. But now there's lots of funding opportunity announcements and funding opportunities, but this should continue. So that should go from the funders level, and even institutions should be valuing the people who are doing implementation research and implementation practice. It should be happening even beyond academic institutions where, whether it's NGOs or health facilities, should be valuing and using these principles, because part of it is that people don't understand what it is and devalue it. And one of the places where they devalue implementation research and science is in the fact that you have to involve multiple stakeholders. And so it's coming from a place of what I'll call epistemic arrogance, right? Where if you're doing something, it loses vigor because certain undesirable people are being included in the chain of events, which is not what implementation science is about. So I'll stop there. Thank you.
Thanks, Nadia. Over to you, Jen. Based on your presentation and the work that you do, a lot of researchers in this audience and program managers, especially from low and middle income countries, do fantastic research, come up with lots of evidence, but there is always a challenge around translating that evidence into policy and practice. In fact, in many countries, including some of the countries I work in, the governments and the policymakers will consider evidence that comes of World Health Organization first before they consider evidence that gets generated in their countries. So what some researchers do is that get the evidence generated, then take it to WHO and work at the global level for WHO to bring it back into the country for it to be adopted. So how can we change that? How can we equip the researchers and the program managers to better disseminate and if I may use the word convince the policymakers to adopt the evidence that they generate from their work?
That's such a great question, and it really partially depends on the context in which you work, but exactly the problem you laid out. I mean, if you follow that through its logical conclusion, it's years before that great evidence is going to come back and be seen by anybody in the Ministry of Health or Finance, whoever needs to see it. So I think while every political system and every context is different, there are some common aspects to it, and finding, whether it's the actual researcher yourself or finding the community organization, the advocacy organization, or building those relationships with the people that are in power, is the way you start to do it. I mean, there's not like a magic solution. It's really that kind of relationship building to find the opportunities to get that information more quickly to those who need to see it. And as Nadia said, really being very sure about the quality of that information, just because it's implementation research, it's rigorous and it's important. The other thing I would say is it's partially that. It's partially also thinking about where are those you want to see the information or use the information, where did they go for their sources? So is it the radio? Is it the news media? Are there certain colleagues that they look to besides the WHO and besides an international organization? You have to find that place that they're going to and work that angle. I mean, again, maybe it's very obvious, but I think a lot of times we forget this piece of it. And while I still think going to WHO and sharing those findings in that way is a great path and should be done, there have to be other ways to do it. I mean, that's what we try to do in the U.S. And I think one challenge is the U.S. environment, particularly in D.C. around global health issues, has a much more very well-established community of people who do this. And when I talk to colleagues around the world, they say we wish we had that kind of established community of actors who know how to take information and reach decision makers, and that maybe that goes back to funders not necessarily supporting that work, but I think that's critical. If we want adoption of evidence, we need to have that part of the translation process supported.
Thank you. To you, Peter, in your presentation, you showed us the network you've built around NIH to come together and fund and support implementation science work. But we also know in global health there is a lot of funding that goes towards implementation work, the public health programming. And often these two funding streams are separate. But we would expect that the evidence generated from implementation research informs those programs. So what can be done to harmonize these different funding streams to help us build a broader coalition, an interdisciplinary collaborative, that at least those who fund and implement public health programs or even clinical programs are connected to those who are also funding the implementation research in a way to create a structured process for the uptake of that evidence that eventually gets generated. And also sort of rebalance the scales when it comes to how resources are invested. So we get more going into implementation science. Thank you.
Yeah, thanks, Deus. That's the work. That's what we really are working, and that's what Nadia's doing. That's what Rachel's doing, is really to try to strengthen that ecosystem and bring those different groups together: the researchers, the implementers, the policymakers, the funders. And I think over time there's building up a just familiarity. Personal familiarity, so people in the country actually know each other, but then also familiarity of the different fields. And so a policymaker should have better understanding, and part of their formation should be, how is research done, how do you interpret evidence, and et cetera, across each of those different groups. So a researcher understands through Jen's work how policy is made and how to talk to those people. And so it's a process over years to actually improve that ecosystem and to strengthen that. These two are giving such great advice, and I think to bring them together that yes, we do need that rigor and to be able to, write an NIH grant and show here's the theoretical framework, here's the model that I'm using. Of the hundreds of slides that I got, there was a lot of the different models and ways of doing that. But then also when you're talking to a policymaker, they don't want to understand the theoretical framework. They just want to have the message that here's simply what we did, how we showed that it works, and why it should be funded. So to be able to bring the right message, to have that rigor underlying it, but to also be able to just explain in simple terms why it's important and how it makes that impact. When we were putting together the panel, they wanted me to go first and give the definitions of implementation science and talk about the theory. And I said, I'm not a card-carrying, theoretically trained implementation scientist, but in my work at CDC over decades, there was a lot of what I now, in retrospect, would have called implementation research as part of that. And so on the one hand, we want that rigor, but on the other hand, we also need to democratize this and have people who aren't rigorously theoretically trained implementation researchers understanding these principles, practicing these methods. And I'm sort of a CDC 2x2 table trained epidemiologist. If you can't express something in a 2x2 table, then it's hard to actually move the needle in public health around that. So my simple formulation is to put more implementation into research. And so when you're a researcher, think about the implementers, involve them as you're putting together your protocol, your study design, and then on the other hand, have more research and implementation. So the implementers should be constantly thinking about evaluation, constantly thinking about what are the new tools that we're going to incorporate. And so the work that we're doing is bringing those groups together so they understand each other. And naturally, of course, a researcher would think about implementation and an implementer would think about research. Thanks.
Thank you. Before we go to the audience, since you all saved up time as part of your presentation, I have one final cross-cutting question that I'll ask each of you to weigh in, and that is, to keep in line with the conference theme, how do we integrate equity considerations in implementation science when it comes to global health practice? I'll this time start with you, Peter, and then end with Nadia.
Yeah, well, I just, adding to what I said earlier, is there's a need for an ivory tower and to build a rigorous science of an implementation science, but there's also a need to democratize this. And while some hardcore researchers are poo-pooing implementation scientists shouldn't poo-poo the people who are not rigorously trained, not theoretically trained, that are trying to do this, and they need to be brought in. And those voices heard, and different ways of learning and different ways of communicating to be included in it. So to me, that's the equity piece. There's obviously a lot of other elements, dimensions of equity, but I think in terms of the scientific training, the academic field to be more equitable and inclusive around that.
Sure. This sort of picks up from what Peter was saying, but I think of it as when you're an implementation scientist and you're really at the point of trying to figure out what your research is going to be, it's really about who's designing that research and bringing in the different perspectives around research design, research implementation, and monitoring. So it really has to truly address equity concerns. It has to be built into the structure of your approach, which is hard to do for the reasons that maybe Peter said and others, but I think that's truly the way to do it. So that's one aspect of it. The second I would say is it's not just who and sort of how you're doing the research but what you're focusing on. So it's also the purpose of your actual, the thing that you're looking at. I mean, to advance equity, we have to analyze equity. Are things equitable? And that's hard often because because it's sort of like a vicious cycle. The data haven't been collected or analyzed, so we don't have those to go by, and we have to get them. But I think that work has to be done, and it has to therefore be built into the questions that are asked and the way the data are obtained to really try to redress that inequity that's kind of built into the system. And to me, it's those two aspects. It's how you design and think about it and then evaluate and implement, but also what questions you're looking at.
Thanks, Jen. So, whenever we are talking about anything, I try to think of what is the definition or, what is it rooted in? And health equity doesn't have any, borders, doesn't have race, class, or gender, limitations. It's really for everyone. And is a concept where we are working towards every individual being able to attain their highest level of health and well-being. So if that is the approach to which you are supposed to be taking, the approach that you're supposed to be taking for your work and the agenda for global health and implementation science, then that should be the core motivation. So I'll start with what you shouldn't do is what we did with HIV in the beginning, especially, what we've been doing with COVID, and what we've been doing with Mpox. Do not do that, because that's inequitable. And we keep doing this every single time. And so some of the things that came up, especially with the organization of the establishment of the WHO Pandemic Hub, if you haven't heard about it, there's information about it on the WHO's website. Some of the things they were talking about was enhancing methods for access to multiple data sources, developing state-of-the-art tools. State-of-the-art doesn't necessarily mean expensive or inaccessible. Providing the WHO, their member states and partners with these tools, which is everybody, and then connecting and catalyzing institutions and networks. All of these are grounded in equity. But we need to take all of that equity talk and guidelines that are written into action. But we've been failing on doing this every single time, and we only tend to re-engineer the way we are doing things into more equitable ways after a certain period of time has passed, after people have died or have had serious health issues, and after we've realized that we are failing spectacularly. And so we need to stop approaching things that way. Equity must be put into action. So it should be global health equity action. And there are a lot of people with influence and leverage and funding and expertise to get that done. And I believe there are a lot of people in implementation science, implementation research and practice who can do this. So thanks, I'll stop there.
Oh, please go ahead.
For all the implementation researchers there out in the audience, I think in a way this field is the best for considering this question, because the whole approach that we're all trying to grapple with is why is it so hard to get something, have people, communities, individuals adopt an intervention. And we know it's because of all the structural inequities that they face. And so this approach and these theories and these methods are very much, in my mind, designed to really look deeply at those questions. So I think we remember that's the positive here, that I think we have the tools more than other areas of research to embed this work and to make a difference.
Thank you. We now open it up to the audience. You can come to the microphone over there, and if you want, please direct your question to a specific panel member.
Thank you very much. This is a fascinating conversation. My name is Tao Lee. I'm from the University of Louisville. My focus is in digital medical and health professions education, so very much on the implementation side. My question is twofold. To what extent, and perhaps this is maybe for Dr. Nadia, but could be for anybody, is there kind of like a subfield, is there like a sustainability science? Because we all know at some point the funding runs out, right? Either from the research funder, either from the policy funder, or from the NGO or the foundation and whatnot. If an intervention is proven to be efficacious and provides true value to society and community, how do you keep it going beyond when the funding runs dry, right? So is that part of the implementation science world? So that's question number one. Part two was, for those of you that were at the World Health Summit on Thursday, one of the very first sessions was really fascinating. It was about a concept called commercial determinants of health, which I didn't realize really existed. I just kind of thought was social determinants of health. But in that conversation with Ministers of Health and so forth, the policymakers, a lot of it was focused on things where commercial entities are perhaps not helping things in the health space, like extractive mining, things like that. But tying back to the funding and the financial sustainability, commercial entities or other innovative funding or financial sustainability, how can that be tied together in a positive way with CDOH? So thank you very much.
And whoever wants to go first, please feel free.
Okay, thanks so much for your question. And with respect to sustainability, it is a huge area of implementation science. There are frameworks, there's a framework for everything. There are frameworks for sustainability, but you've hit the nail on the head in that it is often one of those places where we don't put a lot of effort in as researchers or even as funders. And there's a growing discourse, a narrative on how we should focus more on sustainability. What's the point of getting the evidence into practice and selecting all your wonderful strategies and, okay, this works and this works this way in this context with these strategies and tools, and not be able to keep it going. And so that's the point at which I know that it is out of my hands as a researcher or even my institute. That is the point at which I have to speak to people at the government level. That kind of sustainability that we are talking about is for huge entities to maintain, not only in funding, but in the practice, the policies, and for lack of a better word, the enforcement of the policies, or making sure that the policies are continued. So beyond a certain point when I'm done doing my work and even having some aspect of sustainability XYZ, I have to talk to people like Dr. Ifedayo Adetifa, who's standing at the back there, who's the Director General of the Nigeria CDC. Those are the policymakers with the power and the leverage. I have to talk to people at Federal Ministry of Health Nigeria, people who are dealing with the HIV program in Nigeria, because those are the people who are going to make it sustainable. I can tell you some of the tools that will make it sustainable, but I can't make it sustainable. It's these entities that need to make it in partnership with the donors that are providing funding for some of our HIV programs, malaria, XYZ, and then WHO as well, right? And so as Jen had said, you have to work the angle, and sometimes depending on who is open to hearing me at certain points, I may go to different people, but that is one of the hardest things in implementation science to do.
I actually wanted to add that this is a very real question and issue right now in so many programs, but I'm thinking right now about PEPFAR and the discussion that we've been having for a long time in PEPFAR, but it's really at a heightened place. And one of the things that keeps coming up in those discussions, and this is about how long will the U.S. government be doing this, and at what level, and how do we is what are the examples that we have from other sustainability efforts? And so that research, there is some research, but I'd say it's not a lot. But everyone looks to that research. So it's really critical. And I think if anyone is interested in this, doing even case studies of sustainability models of large programs, what worked, what didn't work, would be incredibly valuable for all of us working in this space.
And I just want to add a kind of a counterpoint. There's also a science of de-implementation, the opposite of sustainability. There's so many practices that either have no benefit or are not cost effective. I was so impressed a few years ago, the American College of Physicians came up with a list of practices that we should all just stop doing, which is really bold to be able to do that. So there's also a de-implementation science. And just on the commercial determinants of health, and for the most part, in our capitalist system, the companies are trying to make money and return value for shareholders. And so it's, to some extent, it's the role of government to have those regulations to keep those things in check. I would add, food companies and the food we eat is a big commercial determinant of health or of illness. But it's really also then up to the consumers to, this is what we want, this is what we value. And if someone can answer, why does a plant-based burger, which should be cheaper and is more efficient and better for you and better for the planet, why does it cost more than a meat burger? I would love to buy plant-based burgers, but they cost more than a hamburger. I don't get it.
Thank you.
Thank you.
Next question. Trying to keep it short.
Thank you. My name is Dr. Rajiv Chaudhary. I work as a professor of global health in Florida International University. So it's been a fascinating discussion, I just wanted to add. So I've worked with the University of Cambridge for 15 years, mainly setting up trials, epidemiological studies, and also meta-analyzing evidence-based interventions. So when I came to the world of implementation research, and I really love it, I think that's the next logical step, and it's an evolving field. I understand as a medically trained epidemiologist. What I found is there is plentiful of models, frameworks, and theories, but there is also plentiful of evidence-based interventions for a given situation. And we read the FOAs from the NIH and other institutions within it. So an example that I would like to give is that we were working with our colleagues in Geneva, the WHO, trying to implement the HEARTS package, which is an evidence-based guideline for hypertension and diabetes control in low and middle income countries. And so we were trying to understand a better delivery system for it, how we can engage with, for example, community systems. So we got reviews back that, HEARTS perhaps is not the best guidelines. There might be other guidelines out there. So my question is, how, when we draft this grant application, FOAs, whether there is a need for a full summarization of the evidence-based interventions as well. Because we did a lot of meta-analysis and reviews of the EBIs, and trust me, there are lots of bad EBIs as well. So whether there is an honesty that's required at that end as well, besides the myriad of frameworks and models. Thank you.
I guess that's yours, Peter.
I can quickly respond that peer review is a capricious process. And Nadia shares my optimism that there's a lot of funding available, but even in areas where there's a lot of funding available, it's still hard to get funding. It's still certainly well under half of applications are successful. So I mean, one thing would be just to spell out in great detail why this was selected, why that particular intervention was selected. The other is, as always, just to get in touch with the program officer and ask them, how can I optimize my application? What can you help me with my application? It's their job to make you successful.
So I'll just add to that quickly. In terms of, there are many models and there are many EBIs. How do you select them? And if we are talking about this in terms of research or research team, it's really who you are working with and what they're used to using. Really. And then maybe in the country or the context in which you're applying it, what else has been used that you have data on that didn't work or weren't well received. So in my opinion, there's no wrong theory, framework, or model. You pick and you put together and you justify. And then in the grants too, you can also say, there were these alternatives, but we picked this one because. All right, so you are basically looking at what people are used to using, and how mavericky you want to be in going and picking something you haven't used before, because it has great promise to address some of the things you want to address for that particular project. So, thanks.
Thank you.
Brilliant, thank you. I just wanted to add that NCI lists evidence-based interventions, in which I found pretty useful for cancer-related implementation research studies, but haven't seen one for NHLBI, the cardiovascular implementation research that we wanted to be involved in. But just wanted to make that comment. Thank you.
Thank you.
Hi, my name is Pratap. I'm at the Strathmore University Business School in Nairobi in Kenya. I have one of the NHLBI grants around blood initiatives and implementation science grant. Along with running that, I also run a digital health social enterprise based in Nairobi, developing locally appropriate solutions. So the question is really centered around whether the implementation science community is guilty of navel-gazing around where the interventions are going to come from. So we expect that we know where these evidence-based interventions are coming from, and the understanding is that there is a pipeline of university-based research where some of these interventions come from. But clearly, at least my experience from the digital space is that that's not the case. There's a large groundswell of interventions being tried and tested, and there is absolutely no interaction with the implementation science or any research community that's would benefit from working with them, or there's mutual benefit. So the question is really, can we do more, and how can we do more to work with interventions that need to be studied, but are not coming from the traditional streams, and not try and encourage implementation scientists to generate the interventions themselves.
Who wants to go first?
Okay, I can go.
Nadia? Okay.
So what I'm getting from your question and the background you gave was in having things like mHealth and implementation science being more integrated in terms of working on EBIs or working on implementation science projects related to EBIs, and whether or if implementation scientists should be generating their EBIs themselves. Some implementation scientists like myself are also intervention researchers, what we call the traditional research. But then you don't have to be the one to develop the EBI. But the E is very important. It should be evidence-based. Now, for me, there's no limit to what I will implementation science. It should be a whole scope of anything that affects human health, right? So it also is, for those of us, and many of us who have been trained in the intervention research pathway, to open our minds beyond that. And I think that's part of what limits people. They are not used to having, I can be talking to IT people, mHealth people, I can be talking to traditional bone healers or traditional birth attendants to work with me on an implementation science project. So it is really opening the mind up, but part of the opening the mind up is people understanding what implementation science research and practice is, and understanding the wide scope that it can take. And that's part of the education and capacity building that we are trying to do here. So that's just more of a simple answer to your question. Thanks.
Jen?
This is a different, I was thinking about your question and something came to mind, which is during COVID, well, those of us who were very involved in trying to understand how to respond, how to assess what was happening for real people, whether it was rolling out vaccines to real people or understanding how they were or were not getting their needs met. A lot of the information that was being generated was not necessarily generated in an evidence-based environment, yet it had to be shared by researchers in a very quick time frame and informally at times. But and that has risks, of course. And you sort of weigh those against the risks of, but we are fighting this other threat, and we have to figure out how to respond. And I just think there were some excellent examples that one could go back and look at, and some people have, to see how that, almost like informal spot evidence that people would share with each other. Like, in this place, we are doing this to reach very hard to reach communities, and here we're doing this. And those were great interventions that I think others were able to adopt and learn from. So I'm just agreeing with you that there's other ways and locations for that information to come from.
Yeah, I guess just briefly, I was still trying to understand what the issue is that you can, as you know, you can go right from developing something to market to broad use without involving researchers. So we do have an mHealth program that a lot of institutes participate in and is very popular. And then you're probably also familiar with our Data Science and Innovation in Africa program, which is explicitly, let's use data science, let's use bioengineering and innovation and to come up with actual interventions that may result in publications, but more importantly, actually improve population health and provide economic benefit.
Yeah, I think my point is probably that what Jane said, there's a lot of, there are many interventions that are not being studied effectively. I think we seem to be biased towards the bigger work like the Data Science Initiative in Africa, where we expect to be generating interventions from a traditional pipeline, whereas there are many non-traditional pipelines that don't get the benefit of not just implementation research, but wider research.
Yeah.
Hi there, I'm Jessamy Bagenal from the Lancet, and I'm a physician. I just wanted to get the panel's opinion really on implementation scientists and their role in reducing the influence and reliance on external consultancy management firms. Like on a practical level, they're often brought in to do implementation, and we've seen, recent books like When McKinsey Comes to Town, The Big Con, quite how dangerous and wasteful that reliance is. I just wanted to get your thoughts on that sector and what might be good solutions.
Jane, you want to take that
Sure.
first?
I know, it's a tough question. You know, full interest of full disclosure, right after I finished my graduate degree, I worked for 2 years at not one of those, but at a small consulting firm, and it was an interesting experience. And those, I mean, I know a lot of people that would do that work, and they're brilliant and smart. But what I think you're getting at is, it's really there's a lack of transparency in what's motivating that work. And that's just it's systematic because you don't often know who's funding it and what the goals of it are. And sometimes, I mean, this is where I come to where I think in my organization's case, where we're really doing independent work, because the idea there is that we're not being influenced by the money or the positions, and that's tough. I mean, it's hard to do that, but I think that I don't know how to break out of that other than making it more transparent. The process and understanding that what's at play there, so that the solutions that are being identified or the issues that are being identified are truly being seen as gone through a rigorous process in the way that great to talk to key informants. I think I consider that a rigorous part of our research. We all do that, but being more transparent about what's behind the motivation for it. I don't have a solution. I agree that has been brought up as a challenge for all of us. And one other thing I was going to say in terms of my organization's decision to be independent and not take any position, because I feel like anyone you talk to in Washington, especially, will say, "Oh, we're nonpartisan." But we go further than that, and we say we're nonpartisan, but we're non-advocacy, and we don't take positions, and that's sort of. People don't get that, and part of the reason is there's so much money and power behind health issues, and everybody has an ask, and those asks can be fabulous asks, but everybody has an ask. So what we try to do is say we don't have an ask. We're coming with information, and we trust us, or at least we'll show you that this is good information. That's not an answer to your problem, but I think it's it's a different way to look at it.
Yes, I mean, that's part of our mission, is to actually build the capacity so people don't have to just depend on international consultants and can do their own research and generate their own evidence without that dependency. And then part of the implementation science approach is to actually educate the policymakers so they can understand, where is this information coming from? Was it rigorously collected? Is there a hidden agenda? And interpret it more positively. So I would also just make a pitch for KFF, and if you have to give a talk about global health, and I need some slides on what is the global health funding landscape, or who's who in global health, they're the place to go.
I'll just say real quick in response to your question, I've had personal experience with the external consultants coming to pick my brain and then disappearing the information and me never being given credit or seeing how it was used, and I will never allow that to happen again. Ever. One of the things that implementation science has given to people who live and work and implement locally in whatever context you're talking about is that it gives value and validation to what we know beyond the science. All right? And so if someone is coming from some of these external consultancies, what they lack big time is contextual local knowledge. They lack that big time. And that is why they go and pick the brains of people like me who didn't know better at that time, but now I do, and get away with it. So one of the things that we can do as we are learning to be implementation scientists and implementation researchers and live and work in a certain locale, to be very defensive about what we do and about what we know, because the local expertise is there. It's there, and sometimes we don't realize that what we know is valuable. So implementation science has helped me with that, and I'm using that to help others to realize that what you know is something that several years of training for some people outside this country will not give them. And so we've put value on that, and then we put it into our own research and doing the work. But we need to also do the work and get the work shown. So I'm very, very adamant about publishing what we're doing. It's not necessarily only for academic credit, but to put it there and say, we have done it, and we have talked about it. So thanks.
Just a counter example, when those people talk to me, I say, I want to speak freely. Can you promise me that my name isn't going to be with what I'm saying?
Okay, Director General.
Well, thank you. My name is Ifeda Adetifa, and I'm the Director General of the Nigeria Center for Disease Control. Perhaps more importantly, before my role, I was an academic, or I'm still an academic, but it's just say I'm navigating all sectors. And first, a bit of challenge, okay? So we've got implementation science now, and it sort of reminds me of the journey that we've gone through from international health to global health to whatever. Basically, it means everybody in one part of the world going to study problems in another part of the world, okay? COVID-19 vaccine refusal is probably as high as it gets in the United States, but I have not seen studies into acceptance or into vaccine confidence. Everything is about how people in Africa have not taken up COVID-19 vaccines as they should. Of course, forgetting that the vaccines arrived after the waves have, and all of that. So is implementation science not now the latest evolution of, say, health system research, for example? And why is it again, and not to put the spotlight on you, but when I looked at the portfolio of the Fogarty NIH grants, all those research are being conducted in a particular part of the world. Okay, I mean, there's a problem with cardiovascular health and NCDs here, at least maybe among vulnerable segments of the population, which I'm sure is also receiving attention. But recently, US is in the news for how bad maternal outcomes are for a segment of the population. So, so I thought I would, again, you responded to the question about rigor and said who. I thought I would add more for you to deal with them. I think the other thing to also take into account, I mean, as speaker as an academic, we have to write these grant proposals. We have to advance in our career. I think I have evolved enough to recognize that at some level we're a bit dishonest. Okay, not all of the research we do is going to change policy. It's just not possible. Okay, not all of the evidence, the best evidence that is available is going to be taken up. I mean, it doesn't matter how good the evidence you generate is in the UK, for example. If the National Institutes of NICE, or what is the Center of Excellence, do not decide that, okay, based on whatever analysis, this should now be available on the NHS, it doesn't get provided by government no matter what you do. It might be available in private sector or elsewhere. Everybody makes a decision about sort of what government can provide in terms of health, in terms of new drugs, new vaccines, and all of that. And it's just the reality. So yes, I would already have my New England Journal or Lancet paper and make the chair or become Professor Famous. But I think that then the issue is I've got to take up, like Nadia, go find out why the government doesn't want to implement these nice bits of information. To some extent, I think we need to separate the academics and the research and the careers we have on that side from what happens in government. Final point is, so we're implementing. You've generated evidence. Now, what are the challenges to implementation? What are the frameworks? And of course, I was just going to say to you, when you start talking about frameworks and models, it's all academic. So it's just to also remember that. But a lot of times, so when the evidence was being generated, or when somebody came up with a bright idea that, okay, this is a problem, we need to generate evidence to look at this problem, nobody had a chat with somebody like me at that time. Nobody had a chat with the community to find out, yes, a vaccine that prevents pneumonia, childhood pneumonia, will reduce mortality by, I mean, it seems like a no-brainer. Why wouldn't you want to prevent or reduce under 5 mortality? But I don't think the population or the expected consumers are completely dense or daft. It's just that in our NICE, it was such a lovely idea. The MRC gave me funding for it, and I've gone to do it. But at the time, the community has other problems. They might not seem obvious to you or to me, but they do have other problems. And those have not been dealt with in a manner that allows them to look beyond their immediate concerns. Obviously, you can preach all you want about giving a vaccine to reduce under 5 mortality or something to reduce. But if the person's primary concern is where dinner is going to come from, I'm sorry, It's a lot of air. You're just wasting your time. So I think that's important. The engagement when the interventionist or all the partners or the consulting firms are coming to generate this lovely piece of information is not there. And this fits into the next problem, is the whole sustainability issue. Okay, you want government to take up some evidence-based intervention. Government was not even engaged to sort of acknowledge that this is a priority. And if they were engaged and acknowledged it was a priority, you've completely disregarded budget cycles. You know, at what point do they pay for that? You engage at the end when the study is ready. You might need 4 budget cycles before that comes into the budget. And the consequence, obviously, is that people suffer and all of that. And you've said all that. I think a lot has been said.
Can we try and wrap up? We're running out of
A
time.
lot has been said already about what I think is the whole epistemic discrimination, where sort of people's understanding or knowledge about their problems and priorities are completely disregarded, and countries, to an extent, are a bit conditioned to respond to what WHO says or what the CDC says and all of that. So anyway, thought I would.
Thank you. I think we really add this to the panelist discussion points, because I think the recommendations you're making are critical. They form part of the context and make up the barriers and facilitators of uptake of these innovations. So we will not necessarily answer that question, but I'll give each of you time at the end to conclude, and you can decide how you use that time. So the final question from the audience is to you.
Thank you. Yodi Mahendra Datta. I'm Dean of the Faculty of Medicine, Public Health and Nursing, Gajah Mada University, Indonesia. 2 questions. First one, Nadia, you mentioned that there is theory, model, framework for everything in implementation research. Indeed, there's over 100 of them, I know. But to my knowledge, almost all of them were developed in high-income setting, 99% perhaps. Do you think that's an issue, knowing that implementation is highly contextualized? I mean, if that's an issue, do we need more models, framework, theories which are developed in resource-constrained setting? And how do we actually do that, if we want to do that? That's one. Number 2, capacity building. Peter, we talked in the morning, and thank you for that presentations, but we know that most of the capacity building on IR is individual capacity building, and that has its limits. So I don't know if there are schemes of capacity building at institutional, beyond infrastructures, or even at country level, and if not, what are the thinking around capacity building beyond individual capacity building? That's all. Thank you.
So Nadia, as you respond to that question, I will also ask you to summarize your other points you may not have made, and then we'll turn it over to Jen and finally Peter.
Okay. All right. Thanks so much for that question. And really, this is a topic that's right up my alley that I've been talking about with other colleagues, and especially in AHISA. Rachel is smiling because he's like, oh, God, we've talked about this. So you're right. I'd say, overwhelming majority of the theories, frameworks, and models are developed, theorized, and used in high-income countries. So then, if we're talking about context, people in non-high-income countries, or LMICs, for lack of a better term, take these theories, models, and frameworks that were done in a different context, and sometimes they were done for specific areas. Like psychiatry and psychology are very strong implementation science, over here, and a lot of these TFMs, theories, frameworks, and models, were developed, with those in mind. So what do? We try adapting, right? But some of the adaptations are not necessarily things that are suiting our context, and you realize there are certain constructs and domains and things that really don't fit. Like things like governance is so contextually focused that I don't think I can use any theory, framework, or model that has to do with governance without it coming, from locally, from where I work. So do we need more of these? While there are over 100, if they are not serving the purpose of really making sure that we are answering questions contextually, then we might need more of these ones. We might need more TFMs that are coming from LMICs. And towards that, I've actually worked with some colleagues from India who are surgeons. I'm an ID doctor, and these are surgeons. I'm an ID doctor in Nigeria, and they are surgeons in India. I never thought I'd get to be working with people in that. But they said, we have been putting together a bunch of affordable surgical interventions and publishing on them, but uptake is not happening. And we are realizing that we are missing something in terms of getting these disseminated and adopted at the provider level and uptaken by the patients. How can we get this done in our context? So they came up with, at this point, we'll call it a roadmap, not a framework, because it's not really theoretically grounded yet. But we put together a framework, and we wrote it up and did a set of brainstorming and sort of mini Delphi technique to refine these things, and decided to publish it and to apply it to the work that they are doing as surgeons and for surgeons in other countries. And it hasn't been published yet, but it's in press. And really, it's a way for me to think we can actually sit down, brainstorm, do all of these sort of idea-building concepts, and come up with roadmaps that can later on become theories, frameworks, or models. It is a process, but then it is steeped in local needs and local experience. And between these surgeons I worked with, they have, decades of experience. And so these are some of the things you can do. You don't have to be an implementation scientist necessarily to put these roadmaps together. You might need one down the line if you want to make it a formal framework, but you can put these roadmaps together. But these surgeons did a thorough literature search. In their practice also, they've realized these kind of frameworks or roadmaps don't exist and came up with one. So it is possible, and yes, it's a big issue. And so we are working at AHISA to do a scoping review of theories, frameworks, and models, and to see which ones were made in HICs versus LMICs. I already feel the LMIC number is going to be like close to 0, but we're working on it, so thank you. So for my summary, I think one of the things that we haven't touched on too much is capacity building or skill building. I tend to think of capacity as a potential to do something. Having a PhD doesn't mean that you can do X, Y, Z. You've been trained to do it, but now can you apply it and use it? So I think of capacity building as maybe getting a PhD degree, but skill building, or skill is applied capacity. Skill is demonstrated capacity. And so whether we are skill building or capacity building in implementation science, some of the things we have to do is take implementation science out of research only. Make it more practice, implementation practice. We need to take implementation science out of academic institutions only. I think it needs to go into implementing institutions, NGOs, of course, that have the structure and have the capacity and the skill to do this work. We need to expand where implementation science and research are being done, and we need to do more implementation practice. If you go into any country, I'll use Nigeria as an example, there are many, many, many more implementers, implementation practitioners who don't even know they're implementation practitioners, than the implementation scientists or researchers. So why are we keeping it so narrowly defined and only talking about it in terms of IR and not implementation practice? And so what I've started to take on for myself, you saw the 2 towers of our buildings that I was showing, is to draw more people from the Center for Public Health Implementation and actually train them in structured implementation practice, and to say that implementation research is relevant to your work because you can take from there, and you are the ones who are routinizing the evidence, the data, the findings that is coming from implementation research. So for capacity building, we need to now go beyond the scope of grants or academics or degrees only and make some of this in-service training. And the funding that goes to support these things, I'm talking to anyone who's funded here, plus a certain Dr. Kilmax, who is sitting here, that the funding should also be flexible to allow people to really adjust and expand objectives and make it work as they are learning how to capacity build for implementation science. Right, so I will stop there. Thank you very much.
Thank you. Jen?
This has been so fascinating, and I think the questions are my favorite part because, so a couple thoughts on things that were said. One is, and this is a great question, is implementation science just the new health system strengthening, health systems research? I don't think so, because embedded in implementation science is the idea of understanding the context that people live in which people live their lives and experience the world. And I think that's been a challenge with health systems research, which tends to focus more on formal and systems and miss the impact of those systems on individuals and communities and the patterns of those. So hopefully, my view is no. I don't think implementation research is not the next health systems research, but we do need to be very cognizant and aware of all of the challenges that have been introduced. Second, because this was said, and I think about this a lot, if in the U.S., American, I've always known that the U.S. has put itself out as doing the best on everything when that's not accurate. But I think most of us who didn't believe that now see it after COVID. And the examples I was alluding to before about learning as we go around vaccine distribution were in the U.S. I mean, most of the work that I was doing during COVID was focused on what was happening here, and it really was very, very much in this moment of how are we going to reach certain communities that are being left out to get vaccines. And it was an incredible experience to try to see that happening in real time. And I'm going to invoke the work of somebody else who's not here. I don't think he's at the conference, but if you don't know Coletso Makofani, who's at Harvard, he did some really amazing research recently that I got to hear him present, which was during MPOX in New York City, when one of the challenges was there was going to be some vaccine availability, but it wasn't necessarily getting to the populations that needed it. And he was very frustrated that that wasn't happening. And so he and other collaborators, they did a community-based collaboration where it was crowdsourcing really to assess how can we implement this. The problem is people aren't getting what they need because it's not getting to them. And they, through very innovative methods, were able to geographically identify where those at risk were in the city, who then could be much more strategically targeted in a good way to get vaccine. And he talks about that. He did it purely because he was part of the community and wanted to make it happen. But there's a lot of implementation science and theory, because he's a theorist embedded in there, and I think it's just great work. So my final thought, this isn't really a wrap-up, but it's just I keep coming back to when I think about adaptation and implementation, I think about it really of the actors who have the decision-making power first, and less about the individual who you want to get that intervention, because they may never get it if we don't do that first step. Thank you.
Great. So just to respond to Dr. Yodi, so yes, as we discussed this morning, most of our support focuses on training of individuals, and many of them become very skilled at building institutions and really, changing public health and changing the world where they live. But we do, including as part of AHISA, part of it has been small grants to support implementation science networks that have developed in multiple countries. So there is that kind of institutional support as well as training mentors and developing curricula and those sorts of things. But we're not building buildings or stocking laboratories and that kind of thing. And then I really appreciated the viewpoint and discussion coming from Nigeria. And actually, MPOX is a great example of the need for bidirectional learning, where there was a Nigerian researcher who back in 2017 said, look at MPOX in Nigeria, we think it's now sexually transmitted. And he came to an international meeting and people told him, no, it's not, be quiet, we're not going to listen to you. And now, 5 years later, oh, MPOX is sexually transmitted. We should have listened to that guy from Nigeria 5 years ago. So NIH is a big elephant. If you're looking at Fogarty, you're looking at one of the toenails. We're 0.2% of the funding. And our daily work is to work with our colleagues in lower and middle income countries, but also to encourage the rest of NIH to, there's a lot of science there, a lot that can be learned, and to join us in doing that. But we really are increasingly emphasizing the bidirectional learning. Including during COVID, I think some folks know I was very focused on contact tracing and the importance of that in the US and the need to strengthen that in the US. And so we actually put together a webinar with your predecessor, Dr. Chikwe, and Nadia was one of the co-authors on that paper, and we had a webinar with examples around Africa of the real experts in doing contact tracing, and invited a US audience to participate in that, to learn about that. So absolutely want to continue in that vein of having that bidirectional learning. And I think COVID was a great, a friend of mine noted that apocalypse means to uncover, and COVID uncovered some of the real disparities, but also how some of these higher income countries did not perform as well in their use of science and public health as some of our colleagues around the world. So closing thought, if you're a researcher, learn about policy and implementation and invite a policymaker to have a cup of coffee with you. And if you're a policymaker or implementer, learn about research and invite a researcher to have a cup of coffee with you. And what Jen said, I thought she was going to say to give them a nudge, but she said to give them a kick. And I think that's great advice. Thanks.
Let's give a round of applause to our panelists. I'm not going to do any sort of summary of what was discussed. The panelists have done a fantastic job. I would like to thank all of you for turning up on this Sunday afternoon. We were very worried about an hour before the panel that maybe no one would show up. But it turned out it was actually the most attended panel session that I've been to over the last 3 days. But before we all go away, I would like to thank the person who made this panel possible, that kept us on our toes, made sure we showed up, we prepared for the panel, and that's my colleague, Dr. Martine Etienne Mesubi. Can stand up and they see you. Yeah, she was the true brains behind this, and you also her when she welcomed you on behalf of Georgetown University, one of the co-sponsors. So thank you very much. I think this is the last session for the conference, but I think there is a closing ceremony we'll go to, and then there will be a training workshop at some point. Thank you.